everyone. It is noon, so we'll go ahead and get started. I'm Amy. I'm filling in for Julie today. You'll notice I'm a little different if you're regularly on the Geriatric Echo. And I'll go ahead and go over some housekeeping items before we begin. Please remember, mute your audio when you're not speaking. We ask that you please type your name, credentials, email, and facility name in the chat box so that we can keep track of everyone in attendance. There was a link to the evaluation in the email that you received from Julie, so please be sure that you complete the evaluation for continuing education credit. Links to the pre and post test and evaluation will also be put in the chat box as well. I've already put the pre-test in the chat box, so please go ahead and fill it out if you haven't already. As a part of participation in this ECHO session, we ask that you please have your cameras turned on in order to build a more engaging community of practice. And lastly, when it comes to asking questions, you have two options. You can unmute yourself and ask your question, or you can utilize the chat feature to ask your question, and the host will ask the question when there is a chance. And with that, I will turn it over to our presenter, Michelle.
Hi, everyone. I am just going to pull up my slide set. Can everyone see my slides?
Yes, we can.
Wonderful. Hello, everyone. My name is Michelle Benson. I am a pharmacy resident at Lake Region Healthcare, which is a community hospital in Fergus Falls, Minnesota. Also at NDSU, North Dakota State University in Fargo, North Dakota. And today I'm going to be talking about vaccinations, immunotherapy, and medications for COVID-19. We have three main objectives. Our first one, to understand the benefits and recommendations for COVID-19 vaccination, especially in our geriatric population. Second one, to recognize when a patient with COVID-19 would qualify for outpatient treatment. And then the third one, become familiar with treatment options for non-hospitalized adults with COVID-19. Super important note, information in this presentation is subject to change as we get new information about the virus, as new treatment options become available and older treatment options might not work as well. So you want to watch for updates on the status of vaccine recommendations and treatment options from the CDC and state public health departments. Quick review of what COVID-19 is. It is an infection caused by a virus. Proper name for the virus, severe acute respiratory syndrome coronavirus 2, or SARS-CoV-2. Like other viruses, it is evolving and changing over time, and this is what leads to these new variants that we hear about that can cause new spikes in the pandemic. It is spread mostly by person-to-person respiratory transmission, and we know that the risk for transmitting it from person to person is highest early on in the course of illness. A COVID-19 infection can range from completely asymptomatic up into a fatal infection and passing away from the virus. So looking at diagnosing COVID-19, when should we suspect someone might have COVID? If they have a new onset fever with or without respiratory symptoms, which can include cough, shortness of breath, sore throat, runny nose, or nasal congestion. They can also have non-respiratory symptoms such as smell or taste disturbances, and this is usually a loss of smell or taste, as well as muscle pains or diarrhea. And when I look at these lists of symptoms, I think that sounds like pretty much any other viral illness in the world. Nothing about this is super specific. The only one that maybe stands out as different is the smell or taste disturbances, which is why I highlighted it here. So if really anyone has any type of symptoms, it is a good idea for them to get COVID tested, even if it might not be COVID, just because when we catch COVID earlier, we can isolate to try to stop the spread. And the earlier we use our therapies, if they are going to get treated, that is when they work best. And also, in order to qualify for therapy, it has to be fairly early on in the course of illness. When we're looking to do a test for COVID, there's two types. The one that's probably done more often are our rapid tests. This is usually a nasal swab. You can get your results in about 15 to 30 minutes. Only downside, it is slightly less reliable than our laboratory tests, which is usually a nasal swab or a saliva test. But these results don't come for 1 to 3 days. It is more reliable. You'll see this more in a healthcare setting though, or in symptoms who's having symptoms over time and they keep testing negative. Shifting gears, talking about how to prevent getting ill when you get COVID with a COVID-19 vaccine. Vaccines are recommended for everyone ages 5 and older. We have 2 mRNA vaccines. One is the Pfizer BioNTech vaccine. The brand name is Comirnaty. I have never heard anyone call it that. I'm going to continue to refer to it as the Pfizer vaccine, as most other people do. And then we also have the Moderna vaccine. Brand name is Spikevax. I'm going to be calling it the Moderna vaccine. We also have a viral vector vaccine, the Johnson & Johnson vaccine, which works less well than our mRNA vaccine. So in almost every circumstance, we're going to recommend an mRNA vaccine over a viral vector vaccine. The only reason you would really get a Johnson & Johnson vaccine is if for some reason it was the only one available. And as supplies have improved, that's really usually not the case anymore. Or perhaps if you had someone in front of you who said, I will get one vaccine now and never again, that's really the only other scenario where you would look to do Johnson & Johnson. And differentiating between third dose and booster dose, because this comes up, a third dose is for someone who is not going to mount an immune response to the initial vaccine like most people would. So this is part of the primary series when you're getting a third dose, and that is different than a booster dose. A booster dose is getting an additional dose of vaccine to enhance or restore protection, which may have waned over time. Then looking at mixing and matching manufacturers, this is recommended when you're doing your booster dose. If you got the Pfizer vaccine for your initial series, you can get the Moderna booster, or vice versa, but not when you're doing the primary series. If you're doing your first 2 initial doses, you want to stick with the same manufacturer. But when you're doing the booster, they think you might get slightly higher immunity if you switch to the other manufacturer. This is the COVID-19 vaccination schedule for regular immune function people. We will talk about immunocompromised in a few minutes. So those 5 to 11, the only approved vaccine right now is Pfizer. There is always talk about them approving a vaccine for kids younger than 5, possibly this summer, but nothing set in stone yet. For kids 5 to 11, there is no booster recommendation. It is just going to be the initial 2-dose series and 3 weeks in between those doses. If you are 12 to 18, you can get a Pfizer vaccine primary series, and also they are eligible for a booster. First and second dose, you're going to be 3 to 8 weeks apart, and your booster at least 5 months after your second primary series dose. Moderna is approved for those 18 years and older. Primary series is again 2 doses, 4 to 8 weeks apart, 1 booster at least 5 months after your second dose. And Johnson & Johnson approved for 18 years and older, 1 dose for the primary series, 1 dose for the booster. And you want to do that at least 2 months after your first vaccine, which again implies that it does not work as well as our mRNA vaccines. So the reason they've extended this interval out to 8 weeks, and this is really only for people who are not immunocompromised, 12 to 64 years old. They think if you wait a little bit longer between your first and second dose, it might help boost your immune response a little and also lower the risk of myocarditis. It is a very, very rare side effect of the vaccine, some inflammation involved in the heart. Highest risk population would be males 12 to 39 years old. And so for those individuals, if you could space out that interval longer, it could lower the risk even more. And again, vaccine risk for myocarditis is lower versus than if you got COVID, the risk is higher to get myocarditis. And then this is where things start to get less clear when we're talking about second boosters. The only people there is a firm recommendation for a second booster is if you're between ages 18 to 49 and you somehow got a Johnson & Johnson vaccine for your primary series and your booster, then they want you to do 1 dose of an mRNA vaccine at least 4 months after your Johnson & Johnson booster. For everyone else, adults age 50 years and older, the language is you may choose to receive a second booster dose at least 4 months after the first booster. So things they think you can consider if you want to get a second booster or not, if you have a medical condition that puts you at a higher risk for having a bad bout of COVID-19, if you live or interact with any immunocompromised people, if you're in an occupation which higher your risk, such as healthcare, or if you live in a community where there's higher spread. So in those situations, it might be reasonable for those people to get a second booster. But in the general population, if you're not at risk, the data is not as strong versus getting a first booster. Then talking about immunocompromised people, this is not an all exhaustive list of people who would be immunocompromised. This is a list provided by the CDC of people who would be immunocompromised. So people who have any type of solid cancer, blood cancers, have had an organ transplant and taking therapy to not reject those transplant, CAR T-cell therapy or HCT. If you have a primary immunodeficiency, advanced or untreated HIV. And then there are a lot of medications that lower our immune systems, usually to help us function, but then can also put us at a higher risk if we get something like COVID-19. Here is our vaccine schedule for our immunocompromised people. Again, age 5 to 11, the only vaccine approved is Pfizer. The difference is the primary series is going to be 3 doses. You'll do your first dose, then 3 weeks later, a second dose, and then 4 weeks after that second dose, a third dose, but there is no booster still for anyone ages 5 to 11. You're 12 years and older and have a Pfizer vaccine, you are eligible for a booster at least 3 months after your third dose. Same for the Moderna and those 18 years and older. 3-dose series, first and second 4 weeks apart, then second and third at least 4 weeks apart, and then that booster at least 3 months after that third dose. And Johnson & Johnson vaccine, you're 18 years and older, the primary series is that first Johnson & Johnson dose followed by an mRNA vaccine. They really want you to get one if you've only just had the Johnson & Johnson, and then another booster at least 2 months after the Johnson & Johnson. Okay, and looking at second boosters in our immunocompromised patients, the language is still not very clear. It says people who are moderately or severely immunocompromised might consider getting the second booster dose as soon as possible, 4 months after their first booster dose. I think it's totally reasonable and usually a good idea for immunocompromised people to get a second booster, but we have to consider their degree of immunosuppression and also immunosuppressive therapy timing. If people are on these immunosuppressive medications, you usually have to stop or alter therapy. So if you are working with someone you think might be eligible for a second booster and who should get one, I would work with their provider who is managing that condition to see if there would be a time in their therapy where it would be a good place for them to get that vaccine. Okay, so why do we recommend COVID-19 vaccines? I think this image does a great job of displaying that. Here we have rates of COVID-19 deaths by vaccination status. We can see a huge gap between our unvaccinated, that's black line, versus the vaccinated with at least a primary series. And a Kaiser Family Foundation study, and they do a lot of healthcare research. They found from June 2021, which is when they say around everyone in the US had access to vaccines, to March of 2022, there are at least 234,000 Americans who died, who if they had gotten the vaccine, those deaths could have been prevented. These differences in vaccination and mortality are even greater in our older adults. We can see these purple lines are those 80 plus, those huge gaps in mortality for the vaccinated, unvaccinated, especially when we had that January spike of COVID. We see this as well in the 65 to 79-year-old population, but this is a population where vaccination can make a very large difference in mortality. And then why do we recommend booster doses? So this is rates of COVID-19 deaths by if you got the vaccine and then if you got the booster, and this is looking at specifically people who are 65 or older. Highest mortality is always going to be the people who didn't get the vaccine at all. And then our two blue lines at the bottom, if you got just vaccinated with a primary series, you are seeing a higher rate of mortality when we're having those COVID-19 spikes like we did in January of 2022, versus if you got a booster, there is a lower mortality rate. So want to recommend boosters for everyone. So COVID-19 vaccine safety and side effects. There is a misconception out there that the COVID-19 vaccine came out super fast and that must mean it's not safe. The vaccine did go through all standard preclinical and clinical stages of development with the same stringent and then the FDA put it to the top of the list to look at, but it still went through the same trials and data collection that every other vaccine comes out. Something going on. All right, I was just saying you should wait to use over-the-counter Tylenol, ibuprofen, because the thought is that if you do it before you get a symptom, that you might be messing with your body having an immune response to the vaccine. There's not a ton of data to back that up, but it's better safe than sorry to wait until after you have those symptoms. There are also rare serious side effects with any vaccine or medication, but for the most part, millions of people have gotten these vaccines right now, and they are very safe. Common questions that come up about the vaccine. People ask, I've heard that you can still get COVID-19 even if I get this vaccine, so why should I? Unfortunately, we don't have any vaccines in existence that are 100% effective, and the main goal with our vaccines are to prevent hospitalizations and deaths rather than mild COVID-19 cases. So even though we can't offer 100% protection, it's still much, much better than not getting a vaccine. People also ask, why is there different coverage versus the different variants? Because the virus is evolving and changing. Sometimes our vaccines work a little less well than they did with the previous variants that they were designed to protect against, but we are still seeing they are largely effective against hospitalization and deaths. So even if they don't work as well, they are still better than nothing at all. Again, it used to be a recommendation that if you have had COVID-19, you couldn't get vaccinated for at least a couple months. This is no longer the case. Once you have fully recovered from COVID-19, no more symptoms, you can get a vaccine as soon as possible. So this might be a nice time to target someone if they've just had COVID-19 and they recovered. They didn't get a vaccine before and they would not like to get COVID again, because just because you've had COVID once does not mean you can not get COVID a second time. So as soon as you fully recover from a COVID-19 infection, you can get vaccinated. I brought up earlier the risk of myocarditis or pericarditis, so rare inflammation involving the heart, a lower risk with the COVID-19 vaccine versus than if you actually got COVID-19. Vaccine skepticism is common. About 82.4% of people over 5 in the US have received about 1 dose of the vaccine, but that means there's about 20% of people in the US who have not had a single dose at all. When you're talking about people talking to people who don't want to get the vaccine, it's important to listen, but don't judge. It is not a moral thing whether people get the vaccine or not. I know a lot of people who I think are excellent and healthcare providers who I think are excellent who have not gotten the vaccine. It doesn't mean they're bad people. People have reasons for the decisions that they make. But if you are talking to people about the vaccine, you want to make sure to have information and resources available. There is a ton of misinformation about the vaccine out there, although you never want to call people something rude if they're coming up with misinformation. Just say, I have this information available too. You never, ever want to get into politics with the vaccine. It makes me sad that people try to make it a political issue. I am only recommending it due to the data that I've seen that I know it can use to prevent hospitalizations and deaths, nothing to do with politics. If you are looking to raise vaccination rates in your area, you can ally with community influencers. There are a lot of people who aren't connected to the healthcare system or don't really trust the healthcare system for very good reasons. So trying to get involved in people with the community, like people at the school, community centers, people who are trusted, promoting that vaccine versus just coming from you, a random person they don't know. We always want to be respectful from talking about the vaccine. I mentioned this already. The debates can get heated, but we always want to respect each other. And then be prepared to play the long game. This pandemic has already been going on for a long time. Maybe someone who didn't want to get the vaccine initially has thought about it more and changed their mind. Of course, if someone says, no, and you already asked me about this and I never want to talk about it again, you don't want to bring it up, but it's perfectly reasonable to ask someone more than once if they have thought about getting a COVID-19 vaccine. Okay, then shifting into talking about COVID-19 outpatient management. About 80% of people who get COVID-19 have only a mild illness that does not require medical intervention or hospitalization. There is no fixed criteria for hospital admission, but people who you think would want to be seen would be those having shortness of breath, any drop in oxygen status, chest pain or tightness, kind of those alarm cardiac symptoms, dizziness, confusion, or any changes in mental status. For anyone who has COVID-19, we're going to want to do supportive care. We can look at doing COVID-19 specific therapies, which we'll talk about next, and then isolating to prevent the spread of that virus. Then for every patient, we're going to manage symptoms. So if they're having cough, giving them cough medicine. If they're having sore throat, like lozenges. We want people to eat. I know when people aren't feeling well, it's hard to eat, but the more that we eat and stay with adequate nutrition, the better our bodies can fight off these infections. And then also paying attention to the risks of social isolation. Even though you have to isolate when you have COVID, it already feels crummy that you're sick, but then being alone doesn't make it better. So trying to connect people with friends and family through virtual things, phone calls, anything we can do to remind them they are not alone. I've said this before, but it's super, super important. Therapies for COVID work better earlier in the course of the disease. So if people are having symptoms, the sooner you can get them tested and the sooner you can get them therapies, that is when they will work the best. This is our list of our COVID-19 outpatient medications. One of them is a pre-exposure prophylaxis medication. So this is what we use before people get sick. It's called vusheld. And then we have 4 treatment options for non-hospitalized adults, and they are listed in order of preference. So our number 1 choice is going to be Paxlovid, followed by Remdesivir, then bebtelovimab, then Molnupiravir. We also used to have more treatments. They're listed here. As the variants came out, they became less effective. Really only put them up here as a reference in case they ever came up again, which they could if variants continue to change. So I'll take a second to define what is a monoclonal antibody. We talk about them a lot with COVID. So antibodies are proteins used by our immune system, and they flag a certain foreign object in the body to alert the immune system that it's in there so they can come take care of it. Whereas monoclonal means that something is made by cloning a unique white blood cell. So a monoclonal antibody is designed to specifically bind certain substances in our body to let the immune system know that they're there. So first medication we're going to talk about is vusheld. It's a combination mAb with tixagevimab and cilgavimab. They bind to certain proteins on the virus, and this is only for pre-exposure prophylaxis in immune-compromised patients who are 12 years or older. If you are going to look at giving vusheld, it has to be given at least 2 weeks after vaccination. It is an IM injection of both of the drugs, 300 milligrams as a single dose, but we're going to do it in 2 separate syringes. And previously, like months ago, the dose used to be half of what it was, 150 milligrams. So if there are people out there who only got the 150 milligram dose, they can repeat with the second dose of 150 milligrams to get up to the recommended dose if their first dose was greater than 3 months ago. However, right now, there isn't timing about repeat dosing beyond that, just due to the uncertainty of if it's going to be effective to redo it over and over. All right, and then looking at drugs for people who have COVID-19, who are not in the hospital, but we want that to prevent them from getting sick and needing to end up in the hospital. Our first choice is Paxlovid, which is a combination of 2 antiviral drugs. One of them is called nirmatrelvir, and it's a protease inhibitor, and it blocks the virus from making proteins, so it's no longer able to replicate. The other medication in Paxlovid is called ritonavir, and it's involved in inhibiting something called CYP450. It basically blocks the metabolism of nirmatrelvir, so there is more nirmatrelvir in our system. Paxlovid in clinical trials reduce the risk of hospitalization or death by 88%, so it works very well. That's why it's our #1 choice. It must be started within 5 days of symptoms, so it is pretty early on in the disease course for getting Paxlovid. Paxlovid will come each dose as 300 milligrams of nirmatrelvir with 100 milligrams of ritonavir twice a day for 5 days. So it's 2 pink nirmatrelvir tablets with 1 white ritonavir tablet in the morning and evening. So they'll take 3 pills in the morning, 3 pills in the evening, for a total of 6 pills a day and 30 over the total course. So it is a pretty hefty pill burden for those who can't swallow very well. And then, like I mentioned, because ritonavir is involved in blocking metabolism, Paxlovid has a lot of significant and complex drug-drug interactions. If people are on other medications with drug-drug interactions, it needs to be managed by a healthcare provider or a pharmacist to either alter or stop therapy for a couple days. Or if they can't be stopped, Paxlovid might not be an option for people. There is also adjusted dosing for renal function. So in people with renal dysfunction, they will get a slightly lower dose of Paxlovid. So that is something you need to check before prescribing this. Next, we have Remdesivir. You might have heard of Remdesivir previously because we also use it in inpatients. It is a broad spectrum antiviral. It makes itself look like part of RNA when viruses are making RNA. It is a shorter duration of treatment versus when we use it in inpatient. It's only going to be 3 days for an outpatient versus in the hospital. You can give it for 5 to 10 days. In clinical trials, a 3-day course of Remdesivir had an 87% reduction in the risk of hospitalization or death. You want to start it within 7 days of symptoms, so you have a couple days more versus the Paxlovid. It is an IV infusion. We do 200 milligrams on day 1, then 100 milligrams on day 2 and 3. The thing that is less great about Remdesivir, you have to give it in a setting where you can manage hypersensitivity reactions. The infusion is going to be 30 to 120 minutes, and then you have to watch patients for at least an hour after the infusion. So there are a lot more logistical considerations versus our other treatment options. And not only do you have to come in for an hour, 2 hours plus for Remdesivir infusion, you have to come for 3 days in a row, which is a high burden on the healthcare system for bringing in someone with COVID and dealing with that, monitoring them and doing the cleaning. I know our hospital decided not to offer Remdesivir for outpatients, and I'm sure there are other hospitals who also thought we just can't take that on in addition to doing patients at the hospital. Our third option is bebtelovimab. It is another mAb. It will bind to a protein on the virus. The thing that is less great about bebtelovimab is that the data about this mAb mostly comes from in vitro studies. So studies that were done outside of the body, but they modeled things that would happen in our bodies. You're going to want to start it within 7 days of symptoms, and only if none of the preferred therapies are available, feasible, or clinically appropriate. The one nice thing about it is an IV push. You can give it over 30 or more seconds, but it still has to be in a setting where you can manage any type of hypersensitivity reaction, and you still have to monitor patients for at least an hour after the infusion. Our last outpatient option is Molnupiravir. It is an antiviral. It makes itself look like a part of RNA to promote mutations in the virus. Clinical trials, it reduced the risk of hospitalization or death by only 30%, which is why it is pretty much our last line option, although 30% is better than nothing. Want to start it within 5 days of symptoms, again, so pretty short duration, and only if none of the preferred therapies are available, feasible, or clinically appropriate. Like Paxlovid, there's a pretty high pill burden. The dose is 800 milligrams twice a day for 5 days, comes in 200 milligram pills. So you need to take 4 of those twice a day for 8 pills a day, 40 days or 40 pills total. When it comes to locating outpatient medications, the government has actually made these really handy tools. They actually work really well. I know some things made by the government are not that user-friendly. This is actually very user-friendly. If you're trying to find where you could get Paxlovid or Molnupiravir, you want to go to the COVID-19 test to treat locator. Here I put in a screenshot where I put in the Fergus Falls zip code, and this shows me that there are Walgreens in my area that cover or that carry Molnupiravir or Paxlovid. They also have a phone number if you need further help. And then there's a different site which includes bebtelovimab and vusheld 2, the COVID-19 therapeutics locator. Here I once again put in the Fergus Falls area code, and you can see that our cancer center has access to vusheld at Lake Region, and then Lake Region Healthcare does carry and offer bebtelovimab. So these are super useful resources for trying to find where people can get COVID-19 treatments. And then just a little bit about long COVID. It is fairly common to have physical and psychological symptoms following a COVID-19 infection, and this can be feeling tired, shortness of breath, chest pain, coughing. You can also have psychologic or cognitive symptoms. Sometimes people describe that brain fog. Most people will recover in about 2 weeks, but longer recovery is more common in those who had a severe course of the disease. And in those cases, this can be a few months or even longer. The reason we don't talk about long COVID as much is there is no specific therapy available for any type of post-COVID symptoms. We're just going to refer and treat as usual. If you're having symptoms, you would send someone to primary care, and if it involved a specialty site, you were having neurologic problems, you would see a neurologist like you would for any other type of illness. The only thing I've seen that's unique to COVID is that there is some data for olfactory training, people smelling different substances to try to regain their sense of taste or smell after COVID. So a summary of what we've talked about today. I want to recommend everyone over 5 years old to get their primary COVID-19 vaccine series and booster, especially in our older adults. Second boosters are available for certain populations, but there are no concrete recommendations about them. You want to deal with vaccine skepticism with patience and compassion. There are antiviral and mAb treatments available for non-hospitalized adults who have COVID-19. And these treatments are ranked in order of preference. Each has their own pros and cons. And the availability of these treatments can vary widely by your location and demand, although the government has put out resources to find what's available in your area. And then I have a couple of patient cases. And these are both based on patients that we've seen in our area. So for our first one, we have a 71-year-old female who calls your clinic stating she did a home COVID test today. It was positive. Her symptoms started yesterday and included chills, sweating, sore throat, and body aches. Her pertinent past medical history includes atrial flutter, which she takes warfarin and diltiazem for, COPD, heart failure, and hypertension. And we know that Remdesivir is not available in your area. See people answering Paxlovid, which is true. And in this case, we actually did recommend this patient go out and get Paxlovid instead of giving a mAb, and that is what they did.
People who have had COVID, and their thought process is that they're a lot better protected because they had COVID than getting the immunization.
Yes, so it is true if you've had COVID that it does give you some immunity against the virus. It is not going to be as good as a vaccine series.